Order, order. John Howell to move the motion.
Thank you, Mr. Owen. I beg to move that this House has considered the use of ambulatory care. NHS, I start this by referring back to a publication produced by NHS England, which prompted me to call for this debate. NHS England has recently published this multi-agency quick guide and supporting information to support local health and social care systems to reduce the time people spend in hospital. It acknowledges the fact that people's physical and mental ability and their independence can decline in a hospital bed. For people aged 80 and over, 10 days in hospital equates to 10 years of muscle wasting. The report, therefore, recommends that people should seek to make decisions about their long-term care outside of hospital, preferably in their own home or in a bed where their true long-term needs are understood. This is a report that's not been prepared by government, but by the Emergency Care Improvements Programme of NHS England. It adds to the overwhelming clinical evidence that this approach is by far the best way of proceeding. The report goes on to say that care at home enables people to live independently and well in their preferred environment for longer. The report contains checklists of questions for patients and commissioners to deliver this situation. I'm immensely encouraged by this, as this is on this basis that the number of beds has been worked out at Townlands Hospital in Henley, and the answer of up to 14 initially associated with the hospital has been reached. These are to be associated with the hospital, but to be set in the care home at the side of the hospital. It is reassuring to know that we are at the forefront of current thinking and action. It's a view that's supported by organisations such as the Alzheimer's Society and clinicians throughout the NHS. It is the right way to proceed and in the best interests of the whole of the community. Before I continue, I probably ought to say what ambulatory care is. Ambulatory care is besides the description that I've just given, ambulatory care is medical care provided essentially on an outpatient's basis, including diagnosis, observation, consultation, treatment, intervention, and rehabilitation services. And this care can include advanced medical technology and procedures, and the costs of doing that should not be underestimated. Under this new care model outlined in the NHS 5-year forward view, GP group practices would expand and would include nurses, community health services, and particularly social workers. These practices would shift the majority of outpatient consultations in ambulatory care to out-of-hospital settings. If we turn to look at the effects of hospitalisation, for many older persons, hospitalisation results in a functional decline despite the cure or repair of the conditions that took them into hospital in the first place. Hospitalisation can result in complications unrelated to the problems that caused admission or to its specific treatment for reasons that are explainable and avoidable. Usually, age is often associated with a number of functional changes, which I'm sure that you and I, Mr. Owen, have no experience of at this stage in our lives. But they include things like a reduce in muscle strength, reduce in aerobic capacity, and other features such as that diminished pulmonary ventilation, altered sensory confidence, appetite and thirst, and a tendency towards urinary incontinence, which I am not saying that any of us suffer from. Hospitalisation and bed rest superimposes factors such as enforced immobilisation, reduction of plasma volumes, accelerated bone loss, increased closing volumes, and sensory deprivation. Any of these factors may thrust vulnerable older persons into a state of irreversible functional decline. So hospitalisation is a major risk for older persons, and I'm talking about particularly the very old here. For many, hospitalisation is followed by an often irreversible decline in functional status and a change in quality and style of life. A recent study in the US showed that of 60 functionally independent individuals, 75 years or older, admitted to the hospital from their home for acute illness, 75% were no longer independent on discharge, including 15% who were discharged to nursing homes.
Will my honourable friend give
Of
way?
course.
I'm not in any way, of course, suggesting that my honourable friend needs to take the weight off his feet after that sad list of symptoms. While he is quite rightly concentrating on the needs and degeneration of older people who go into hospital, does he agree with me that ambulatory care is, of course, important for younger people as well? I know that in our local general hospital, the Horton, there is a marvellous new children's outpatient service, which is used by both his constituents and mine. And does he agree that this is a centrally important part of the offer of that hospital, which provides inpatient care in an acute way, as well as the outpatient care on the side?
Well, I thank my honourable friend for allowing me to have a rest and to make the most of that time. As I'm getting older, I need that now. I do agree with her. This is she makes a very valid point. I'm concentrating on the older people because traditionally that is where the population that have used the hospital in Henley have come from. In fact, I think in the past year only one was under 55. But I think she makes a very valid point. In many cases, the decline that people experience cannot be attributed to the progression of the acute problem for which they were in the first place hospitalised. And even when, if you've got, for example, such as pneumonia, even when the disease is cured in a few days, or indeed a hip fracture repair is technically perfect and uncomplicated, the patient may never return to the same functional status that they had before they went in. Of the study in the US, between 30 and 60% of patients with hip fractures are discharged from the hospital to nursing homes. 20 to 30% of those persons are still residing in nursing homes 1 year later. And only 20% of one large group of patients return to their pre-operative functional level after the repair of a hip fracture. Many hospitalised patients have difficulty implementing their habitual strategies to avoid incontinence. The environment is unfamiliar. The path to the toilet may not be clear. The high bed may be intimidating. The bed rail becomes an absolute barrier, and the various tethers, such as intravenous lines, nasal oxygen lines, and catheters, become restraining harnesses. And about 40 to 50% of hospitalised persons over the age of 65 are incontinent within a few days of hospitalisation. So a high percentage of hospitalised older persons discharged to nursing homes never return to their homes or community. In one study, 55% of persons over at the age of 65 who entered nursing homes remained for more than a year. Many of the others were discharged to other hospitals or long-term care facilities or simply died. And the outcome for many hospitalised elders is a loss of home and ultimately a loss of place. Most importantly, relationships amongst physicians, nurses and other health professionals need to reflect the interdisciplinary nature of the whole of this process. And particularly, I'm a great enthusiast for the integration of the NHS with social care, and that needs to move ahead very, very quickly in order to give the clinicians the responsibility for commissioning the social care that is required. Now, maintaining wellness and independence in the community prevents deterioration in conditions and therefore results in better health outcomes. Emergency admissions to hospital are distressing.
Would the Ombudsman give way?
Of course I'll give way.
Thank you for bringing what is a very important issue to Westminster Hall for consideration. Over the last 5 years in Northern Ireland, just to give an example, we've had an increase in Category A ambulance call-outs by 30.9%. It's a devolved matter, but it does indicate a greater dependence and need for ambulance responses. And I'm just wondering, does the Honourable Gentleman have any thoughts upon the best way of ensuring that the ambulance service and those who are ambulance staff can do better for those elderly people he's affected his debate upon?
Well, I think the honourable gentleman makes a valid point. The point that I would raise on that as a supplement to what he's saying is that the costs of this need to be offset. This is a balancing exercise within the NHS. That the costs that are saved by stopping people going into hospital can be spent on the treatments and on the services that they require in order to get them better. And I think that is a far better way of working in this area. So emergency admissions to hospital are distressing. So better management that keeps people well and out of hospital should lead to a better patient experience. Now, according to the King's Fund, estimates that have been produced by them show that emergency admissions for what is known as ACS conditions could be reduced between 8 and 18% simply by tackling variations in care and spreading existing good practice. This would result in savings of between 96 and 238 million pounds, which, as I have already said, need, as part of the overall management of the NHS budget, can be allocated against the provision of what are often quite expensive services to provide the necessary medical investigations on the spot. One of the doctors in my constituency, Dr. Andrew Burnett of the Sonning Common practice there, said, very few of my patients want to be admitted to hospital. Most people, if they would like to be treated, or indeed if they are nearing the end of their lives, would like that experience to be located at home. And I think that probably applies to all of us. And it's a particular problem, as I mentioned at the beginning, in relation to dementia. Now, I spoke to the Alzheimer's Society about this, and they said that people are often admitted with an acute physical illness on top of their dementia. And the combination of the two can cause their confusion to become worse. They are then taken out of their familiar surroundings and placed in a hospital ward with lots of strange people, strange noises, strange smells, and this can be terrifying for them. They rapidly deteriorate. And the advice from the Alzheimer's Society was to try and keep people out of hospital for as long as possible. And that's why we are striving to develop systems, and the Oxfordshire medical facilities are striving very hard to develop systems that will enable people with physical illness to be managed out of hospital. And this is one of the particular rationales for the new Townlands Hospital in Henley, where the Clinical Commissioning Group, along with Oxford University Hospitals, Oxford Health, and indeed the County Council, are members of the Ambulatory Emergency Care Network, where organisations can learn from each other to develop robust pathways. There are some good case studies that are involved in this, which time prevents me from going through at the moment, but I would draw the Minister's attention to them if he needs to get some examples of how ambulatory care actually works. And if I can give another example of this, of another clinician's view, it is of the view of Pete McGrain of the Clinical Commissioning Group, who have also said that patients who are recently hospitalised are not only recovering from their own acute illness, they also experience a period of generalised risk for a range of adverse health events. Now, we have had cases in the constituency where the health of the elderly has deteriorated following discharge or even in hospital due to other conditions. And the relatives have sought to blame the health service for poor care. When we have followed up this, their complaints investigation has shown that it is not poor care that has exacerbated their distress and their symptoms, but it is a direct consequence of hospitalisation. So, the result of all of this is that I went to see a hospital in Welwyn Garden City, which has no beds in the hospital. It too is having beds in an adjoining care home at the side of the hospital, and it was absolutely heaving with people. And I met a gentleman called Dave, I don't have his surname on me, nor have I asked his permission, so we will just keep it as Dave. And he could not speak highly enough of the treatment he got. He called in every day for treatment and then got on with his life at home. It had revolutionized the treatment he received, which doctors had confirmed would otherwise have required a debilitating 56 days of medication staying in hospital. His experience of hospital stays had shown up the disadvantages of them, and he pointed out that people were so much more likely to improve, as he had, and to feel better, as he did, if they could stay at home. And he was clearly a great enthusiast for this type of service. Now, when it comes to looking at the situation in Henley, there is one issue above all that I've already touched on that I want to re-emphasize, and that was helped by some papers that were forwarded to me from the Health Foundation, which said that they were undertaking a joint research program on the monitoring how the quality of health and social care is changing over the time. And I have been very concerned at the way in which we move forward with the integration of social care and health within the county in order to make sure that it delivers the sort of services that are required in the full context of the patient that is there. But in relation to the hospital in Henley, I am very pleased and very proud that I have helped to deliver a 21st century medical facility for the people, not just of Henley, but of the whole of southern Oxfordshire, and that this incorporates ambulatory care. It is the way forward. It is clearly the way forward, and it is a way forward that I'm sure will work.
The question is, the House has considered the use of ambulatory care. I call the Minister.
Thank you, Mr Owen, and may I thank my honourable friend, the Member of Parliament for Henley, and also my honourable friend, another Member of Parliament for Oxfordshire, both of whom I think have spoken with great expertise about the place that ambulatory care has in a developing and modernising National Health Service. I have to say I cannot better the description which my honourable friend, the Member for Henley, has given of the purpose of ambulatory care and the place that it forms in his constituency, which I shall turn to in a few minutes at the end of my speech. But I would like to add to some of the examples that he has given for the benefit of the House and the record about what ambulatory care actually entails for patients. So to give some examples from around the country, there is, for instance, a clinical decision unit in the Royal Free Hospital, which provides an alternative to admission for emergency department patients who may benefit from an extended observation period. Or one could go to the James Cook University Hospital and see the ambulatory emergency care unit there, which handles nearly a quarter of all emergency admissions and manages a whole range of medical emergencies, including cardiac failure, cellulitis, diabetes, and low-risk gastrointestinal bleeds. At the University Hospital of Leicester, there is a frailty unit, which now supports patients over 70 who need treatment for conditions such as delirium, dementia, fractures. And there is a rapid assessment and treatment unit at Queen's Hospital in Romford, which has greatly reduced the time between a patient being assessed and a care plan being implemented. So that's what they look like in those particular examples. And to add to the example that he has given at Townlands in Henley, where ambulatory units are co-located with an emergency department, patients arriving at A&E by ambulance or as walk-ins are triaged according to clinical need and are directed to the unit for treatment or tests, effectively bypassing the main emergency department. Patients can also be referred by a general practitioner when the patient is identified as needing specialist treatment, tests or monitoring at the hospital, but does not need to stay overnight. Or patients with long-term conditions can be booked in for regular treatments such as dialysis. Ambulatory care units can also focus on returning patients to their homes after treatment as quickly and safely as possible, just as my honourable friend has outlined. And as a result, patients are more likely to have good health outcomes because they avoid unnecessary overnight stays. And I think my honourable friend outlined beautifully the principle behind making sure that people did not need to stay in bed any longer than they need to. The statistics on this, and it is a developing area of academic study are really stark, and he put them plainly for the House's attention. But their core, I think they encompass something rather encouraging, which is that for many patients, not for all, but for many patients, the best principle is to keep on going. And the minute you stop that, and we've seen it all with our elderly relatives, and you stop that prematurely or unnecessarily, you precipitate a decline in condition rather than an improvement. Ambulatory care is an exciting and important approach to providing patient care, just as my honourable friend outlined, and it is going to be central to the developing National Health Service in the years to come. Now, this has not come about by accident. It is based on good science and good academic study, and we are led in the department by the Royal College of Physicians and their acute care toolkit, and by NHS England's Safer, Faster, Better, which he mentioned, which is based on the advice of the Royal College. But while ambulatory care units may vary between trusts, both the Royal College and NHS England provided guidance on what a good unit looks like, so that the underlying principles that all units are built on are the same. These principles fall into three main categories. First, they must be patient-focused, meeting the needs of patients through timely treatment and discharge and bringing together secondary and primary care services to avoid omission where beneficial. Secondly, the effective clinical decision-making is key, ensuring not only that patients in ambulatory units receive the high standards of care we expect from the NHS, but that patients who would benefit from an ambulatory setting are identified early and directed to the service. And finally, ambulatory care needs to form a coherent part of the hospital and wider health system and structure to improve the patient journey flow through the hospital, gaining support from other parts of the system, including CCGs, as in my honourable friend's constituency, and primary care more generally, is key to ensuring potential benefits are realised. So they work well as independent units within acute trusts, but they work best when they are part of an integrated system. And that is why I'm pleased to see that there's an ambulatory emergency care network which allows trusts to share best practice and to understand how to improve their services still better. The Royal College of Physicians estimates that over 30% of patients admitted for medical as opposed to surgical reasons could be treated in an ambulatory setting. And by treating and discharging patients on the same day, emergency admissions are reduced, leaving hospital beds available to those patients that need them the most. So there is an advantage not only to the individual patient, but to the system as a whole, because we're freeing up capacity for people who really do need the beds. Increasing the numbers of patients seen in ambulatory care has the potential also to reduce waits for patients in A&E, which in turn decreases pressure on wards and increases bed availability. In addition, providing benefits to patients in other parts of the system as well through that route. So there are a whole number of benefits which come as a result of ambulatory care, and my honourable friend mentioned the urgent emergency care review and the place that ambulatory care has within that. And I'd like to turn just quickly to his own experience of it at Townlands. And there's some features which I thought were particularly impressive. I think, first of all, the way that the service has been brought together in the Rapid Access Care Unit. I imagine it's called a RACU. Maybe in Henley it's called a RASU. They use the soft C, I'm sure, the people of Henley. But it is the integration of that with the Orders of St John Care Trust next door, which I found really exciting. Clearly, the clinical commissioning group in his constituency has been very thoughtful about commissioning the care that they need, involving other providers of care, and only using the beds that are absolutely necessary. So it is an ambulatory care setting without beds, but if beds are needed, there are 11 beds on a 3-year contract purchased from the Orders of St John Care Trust next door. And if that number needs to increase still further through the usual spot purchasing arrangements that the CCG has, they're able to procure those beds. So the beds are available if they are needed for step-up care for people who are admitted to an ambulatory setting, or step-down care for people coming out of the John Radcliffe or other acute trusts that serve my honourable friend's constituency. So you've got a far more subtle approach to people needing care on an ambulatory basis, one that provides much better patient outcomes, as my honourable friend outlined, which is better for the health system as a whole, and is much more flexible, making sure that resources go precisely where they are needed. And this opens out a much wider point, which my honourable friend has alluded to elegantly, but I will say rather more vulgarly than he did, which is that it asks a very serious question about how we frame community services in the future. There are parts of the country where we have a far older model of community service provision based on large bed capacity in community hospitals, much loved by their local communities, often funded in part by their local communities, and almost in every instance founded by their local communities. But we know also that they're not providing the best care in many cases for patients. And it is going to be a difficult transition often to a better standard of care for patients, which will provide better outcomes and release resources for better outcomes for all patients across the health system. What my honourable friend has done in being able to bring the experience of Townless Hospital to the attention of the House is that he has shown how by being thoughtful and by being direct with constituents about the implications of change, by explaining carefully how improvements which on the face of it might be challenging, because it might seem that you are losing one particular benefit, in actual fact produce a whole series of additional benefits which enable better patient outcomes and a better distribution of resources within the system. And in so doing, he's allowed the House to understand how actually these benefits could be more widely spread across the NHS. And that is where I turn finally to NHS England's plans for ambulatory care. And he will know about the vanguard sites which are in place across the country. Many of them involve the use of ambulatory care systems. There are many different kinds of ambulatory care settings which are involved in these vanguard sites, but the principle remains broadly the same, which is to try and identify those areas and those experiences which replicate the positive experience which I know that he has brought to Henley with the cooperation of his clinical commissioning group, primary care and the acute trusts, and to make sure that that is tested on a system-wide basis, and then we can roll that out across the rest of the country. So we've got 50 vanguard sites which are involving one way or another community care settings across the country. I hope that that will inform a far wider transformation by the end of the 5-year forward view period, which, as it is 5 years, and concludes at the end of this part. I will give way to the honourable gentleman.
When I'm sorry to be coming at the end of this debate. I was delayed by traffic. I would congratulate my honourable colleague from Oxfordshire on securing this very important debate. Would the Minister agree with me that in this rollout, it's very important indeed that the ability, the training, the qualification of home care workers is raised so that they can complement the changes in the service which are involved?
That is absolutely the case, and it's a very interesting and subtle point also that the honourable gentleman has given. And it's partly why, as part of the workforce review that I have instigated, we are looking at apprenticeship models, at nursing associate models, which will help to upskill nurses and care practitioners, not just in an acute setting, but in a community setting. The result of that is that we can provide a far better, more holistic service to patients, both when they turn up at an ambulatory care setting, or indeed at the John Radcliffe, or when they're looked after, hopefully before that happens at home, or when they return from both those places. All of that taken together provides a far better service to constituents. And I welcome finally, Mr. Rowan, the approach of members in this little but important debate, which is that if we're positive about these changes and have a will to explain them to constituents, constituents will quickly understand why this is better for them. Those members who wish to pursue a cruder campaigning method where they will look purely at the numbers of beds provided in any one setting or not, based on a model which was inherited in 1948 rather than one that's relevant to 2018, will be doing their constituents a disservice. And in being brave and being direct with constituents, but also being very clear in explaining the benefits that he has endeavoured to get, my honourable friend has delivered for the people of Henley a far better service than the one that they had last year, and one that will continue to improve through the course of this Parliament.
The question is, the House has considered the use of ambulatory care. As many of that opinion say aye. To the contrary, no. The ayes have it. The ayes have it. Order, order.